Again, my name is Osama Kashlan. I'm now at Cleveland Clinic, but I'm moving from New York Presbyterian. And I'll be talking about Uni-portal Endoscopic Interlaminar Discectomy. So I have two conflicts of interest. I'm teaching faculty for both JOIMAX and Arthrex. And the videos that are in this presentation are not mine. They're Dr. Gologly, who's a great endoscopic surgeon in California, because I don't have access to my old videos. I'm kind of between jobs now, so I had to use his. So all the great work that you see here is his and not mine. So you heard two talks on endoscopic approaches. So as you know, they're interlaminar and transforaminal approaches. For the interlaminar approach, you could use the big scope like what Dr. Kim was talking about for stenosis cases, or the small endoscope for discectomy cases. And that's what we're going to be talking about today. We're specifically talking about lumbar discs that could be treated, or ideally are treated, with an interlaminar approach. However, if you broaden that a little bit more, what does the interlaminar approach in the lumbar spine, what can you do with that? And this is a list here of all the different pathologies which you could treat. But for the interlaminar discectomy, it's for the first two. So if you have a disc herniation, central or lateral recess disc herniation, those are ones that are greatly treated with an interlaminar approach. And then any other lumbar level, if it's just a disc, it's probably best treated with a transforaminal approach. But if it's a disc with ligamentous hypertrophy, even though you could treat that with a transforaminal approach, it's best treated through an interlaminar approach, in my opinion. So the ideal case for an interlaminar approach is a large lateral recess, fresh disc herniation. So again, L5S1, lateral recess, fresh. This is a great case for the interlaminar approach. Because even if you wanted to get this through a transforaminal approach, most of the time the hips will get in your, or the iliac crest will get in your way. So this is a great case to do the interlaminar approach with. So in terms of the interlaminar approach, Dr. Kim went through the details of it. So it's easiest done at levels where the interlaminar window is huge, and you want to tilt the X-ray intra-op to get the window to be biggest, and that's what you see here on the left side of on your right side of the screen, is you're getting the Ferguson angle of the table, or you're tilting the patient in a way to maximize that window. And the great thing about endoscopy, and what separates it from doing this through an open approach or a tube, is you really don't have to take any bone down to remove a disc herniation in most cases if you have a large interlaminar window like that. So after you get this ideal picture intra-op, perfect AP X-ray, and then you tilt the patient or the X-ray to get this view, that's when you're ready to go. So you check the levels, make sure you're treating the correct level. And as you can see here, unlike doing this through a tube, most of the time you're not in line with the disc space. You're kind of creeping up from underneath. And the reason why is that's what maximizes the interlaminar window and allows you to do these surgeries with minimal removal of bone, or no removal of bone, which is usually the case at L5S1 in young patients. So then you get your dilator, and I like to start with a lateral because I'm always afraid of plunging. So I just go under the lateral to get to the bone there, the bottom aspect of the L5 lamina. You check on the AP, and then you start putting your expanding dilators, again, right on top of the bottom aspect of the L5 lamina, right where it touches the ligamentum. And there's a point where you feel the bottom edge, so you feel that you're bouncing on the ligamentum, and then you feel like you're on bone. And that ligamentum-bone junction is the ideal place to start for these interlaminar discectomy cases. So you get your working channel in there, and then these are Dr. Gologly's videos. So as you could see here, when you come in, you have a bunch of stuff there first, and you kind of clear that out. That's going to be just ligaments and muscle, whatever is residual there. If you did a great job of clearing everything out before, and you have a young patient, then sometimes you're lucky and you land right on ligamentum flavum without anything on top of it. And then what you want to do next is, in someone with a large interlaminar window, you don't need to do any drilling. If it's a small interlaminar window, you need to do a lot of drilling. If you're treating someone with ligamentous hypertrophy, you need to do drilling, kind of like what Dr. Kim was talking about with the stenosis cases. But once you find the ligamentum here, so in this situation, L5 is up here, S1 is down here, this is medial, and this is lateral. And what you use, these are just scissors, and you are cutting the ligamentum flavum. When you first start, you'll start cutting kind of strand by strand, level by level, because you're worried that you're going to get a durotomy. But once you get comfortable at this, you start taking big bites at a time. And the thing that's protective is the second that there's any hole in the ligamentum, the water pressure, the saline pressure pushes everything away. So the chances of you getting a dural tear doing this is actually lower than expected. So you make a hole here, you see the epidural space, and then you enlarge that hole, and you start cutting laterally until you feel the medial facet joint. When you do that, usually you're going to be past the shoulder of the traversing nerve root. So past the shoulder of the S1 nerve root, and that's what you're looking for. You want to make sure that you're not in the axilla of the S1 nerve root, unless that's where you want to be. Unless you know that that's where you want to be. You know it's an axillary disc herniation, but you don't want to inadvertently be somewhere that you don't want to be. And the way that you check for that is by starting to dissect these adhesions that you see lateral to the S1 nerve root and make sure that your nerve root is mobilizable. And that's what you could see here. And then once your nerve root is mobilizable and you have enough space lateral to it, you can start pushing the working cannula down there and then rotating it to retract the nerve root away. And then now you're right there where the disc herniation is. Let's say, for example, if before doing this you saw disc herniation out there, I would pull that out. Pull whatever you can out before doing this move, because the less stuff that's there, the less likely you'll cause any type of apraxia injury when you're rotating the working channel, like what you see here. But the tips here is definitely make sure there's more space than where the S1 nerve root is, so that you're not smashing the nerve when you're doing this. And then if there's anything easy to take out in terms of the disc, take it out before you do this move. So it's important to keep that in mind when you're doing these procedures. And this is an introp example showing that you're able to get down to the level of the disc space and able to get a nice decompression. The patient did well. So what are some pitfalls here? These are the pitfalls that I would think are important for someone to know as they're doing these procedures. The first is, for L5-S1, it's really nice. The distance between the facet joint and the lamina and the spinous process is really, really wide. So it's very unlikely for you to go through the facet joint. But if you have a situation where that distance is short, you just have to be cognizant of that. And in those situations, maybe make your starting point more on the medial side than on the lateral side so that you're able to sneak out laterally. But it's doable. And this is an example here. These are more stenosis cases like what Dr. Kim was talking about, but these are patients that me and Dr. Harrison Kim in Korea took care of when we were there. And you see these patients have very vertical facets. They're super close to the spinous process, and you're still able to get a great decompression with minimal disruption of the facet joint. So it is doable. You just have to be thoughtful when you're doing the drilling and maybe start a little bit more medial. And then what about too high or too low of a starting point? Let's say you're not able to get that perfect Ferguson angle for your x-rays. What happens? So we talked about the best angle is the one in the blue here. But if you go too high or too low, it's not the end of the world. It just means that you have to drill more bone to get to the same view that you had with the blue arrow. So it's not the end of the world. You just have to be cognizant of it. And you have to know, okay, if I started with the upper red arrow, I'm going to have to drill more of L5 to get to where I need to be. And if you start with the lower red arrow, then you have to drill more of S1 to get to where you need to be, or in this case, L4 and L5. So it's fine. It's not a big deal with the endoscope because it's angled. You're able to get to it from either one of those three approaches. You just have to be cognizant of it and know that, okay, intraop, I know I'm going to have to drill way more bone than I usually have. Fear of plunging, talked about that earlier. That's why I initially do everything under lateral. You don't have to, but I think doing your approach under lateral minimizes the chances of you plunging, especially if you're at a teaching institution. And then let's say what happens if you're drilling bone, and you don't see ligament underneath. That means you're either too medial and you're in the raphe, or you're too lateral and you're in the facet joint. So then just take an x-ray, see where you are, reevaluate. Not the end of the world. Last thing is second to last thing, over retraction of the nerve. Like you saw from the video, you always want to have some room between your traversing root and the wall before you rotate your working channel. And you also want to make sure all the adhesions are taken care of before you rotate the cannula to make this safe for your nerve root and you're not smashing it at the same time as when you're rotating the cannula. And then when do you know when you're done with your discectomy? ways that you know that are, so for a dorsal decompression, if you're taking the ligamentum flavum now, if you detach it from the top and the bottom attachments, and you're able to medialize the traversing nerve root, you're done. That's a great dorsal decompression. You don't need to do anything more. For a discectomy, I just look at for L5-S1, I look at the back of the L5 body, the back of the S1 body, and I make sure everything is flat in between the two. When you do that, then you know that you're done. And usually when you're done, because of the way that the water pressure is and the light in the endoscope, usually you see the nerve root, and then there's a gap between it, and then there's the floor, and there's a shadow from the nerve root that goes down onto the ventral aspect of the canal, and that's when you know that you're done. So I think it's a great procedure, super slick, minimizes the iatrogenic injury on any collateral tissue that you don't need to hit. But is it better than what we're doing now? And the answer is probably it's the same as what we're doing now. So why do this? So there are a couple of reasons. First, the incision size is a lot smaller. So for patients who want their incision size to be smaller, it's a nice thing to offer. And I offer it to all my patients. As the patient gets larger and the distance between the skin and the lesion gets higher than 8-9 centimeters, even when we're doing this with a tube, our instruments are hubbed. So for larger patients, I'm much more likely to steer them to endoscopic rather than doing this tubular. But at the end of the day, you have to do what's best for you in your hands. The second reason why I think it's very worthwhile is because now we know that it's equal in terms of benefit as the other procedures that we do, as open or tubular. But eventually, we want to get to the cases as a surgeon where the delta between what the standard is and what endoscopic is higher. So like thoracic discs. But you can't jump and just do those cases. You have to start with cases where the delta may be small before you get to those cases where the delta is big and you're giving your patients the best care. So in summary, we talked about how to do an interlaminar disc. And we specifically talked about L5-S1, but it's really similar for patients with higher disc herniations with concurrent ligamentous hypertrophy, and then talked about the pitfalls that make it easier for the surgeon to get on this learning curve and go further in it. So thanks again for everything, and if you have any questions, please let me know.
Osama, a great talk. Even if they weren't exactly your slides, you presented it very well. And I have to say, like my own experience, I've done some of these. I think interlaminar is the most straightforward, I think, endoscopic technique, other than maybe doing a medial facet transection or something. So I do think it's actually a pretty slick operation. So I think one of the other pitfalls, like at least for me, is like I end up being too medial at the beginning. You have a tendency of medializing, and then you're almost across the midline. I mean, you have to force yourself lateral. I don't know. What do you think? Is because the interlaminar space narrows laterally, so you're pushed more medial. I don't know what your thoughts are on that. I mean, for like if you're telling someone who's new to it, what another pitfall potentially.
No, that's a great. So I'll definitely add that. But I think the reason why that happens is because the scope is angled. So you think you're going straight down, but you're actually just because usually the view that you have is with the endoscope pointing medially. So I think you're like, oh, that's straight down, and then you just kind of pushes you that way. So I think that's one thing. And the way to prevent that is once you have your working channel there, I always you're supposed to get it anyway, but the AP shot is nice because then okay, you're always cognizant of how your working channel is. So okay, if my working channel is this angle, and I usually try to hold it straight down, that way I know on the x-ray, if I'm straight down, I'm here. So then if you're going for a disc, just make sure that you're constantly looking at this angle here. And on the same note, after I'm done with the x-ray machine, I pull it back and you keep it at that same angle because then you're like, okay, I always have to be kind of parallel to that. If I'm doing that or doing that, especially if it's someone with a lot of lordosis, you could actually be off by a level. So those are the two things. And then like you said, in terms of the interlaminar approach, it's much easier for a surgeon because it's our usual anatomy. The hard part about it is, I think I overheard it when I was in there, is like the degrees of freedom of the scope. Transforaminal is the opposite. The anatomy is super hard, but once you're in the foramen, you're constrained. So it feels more like you're not as tired at the end of the case.
Right. Oh, great talk. Any other
Oh, so great talk. Thanks
Thank
for giving it. Question about incidental durotomies. So, can you use a durostat through this approach? And what is your workflow if you do get a durotomy? Is it that you convert to open? Do you fix it endoscopically? And how real is the risk of intradural compartment syndrome with the fluid?
That's a great question. So the first part, in terms of a durostat, I don't think they have an endoscopic way of doing it yet. Not as too big, I think, till now. So durotomies. So if you get a durotomy intraop, the first thing that you have to do is make sure that your pressure in your pump is low, because that's the only time when you could push fluid in there and it could go intracranially, and can cause confusion post-op. And I think I've had some of my stenosis patients when I first started, they were taking forever. When I got durotomies, that they wake up super confused. And then they're just in this hospital for a couple of days rather than going home. So I think the thing is once you get a durotomy, lower your pressure to as low as you can for the bleeding not to be a problem. And then in terms of treating it, actually it's much easier than anything else, because as long as there are no nerve roots that are injured, you're able to put some type of onlay and then glue, and it's good enough. If there are rootlets popping out, then you do want to put in an inlay. So get a Duragen or whatever you use and kind of push it in there, to just at least get things out of your way. But the nice thing is because the dead space is so small, it usually doesn't cause any problems. So I've had a lot of durotomies, especially when I first started, and none required me to ever come back and put in a lumbar drain or anything like that. Right. But again, it's because you fill up the dead space with glue, that non-expanding glue. It has to be non-expanding, and some type of dural substitute. And just like call it a day. I don't know, Patrick, any thoughts that you have about durotomies and treatment of durotomies?
Yeah, I agree with you. Especially when if you have a durotomy, if you occlude the channel, that's when intrathecal pressure goes up really high. And you have to get the case done as quick as possible at that point. I'm totally with you on this too, especially, kerosene is a dangerous instrument, right? So when I started off, when I was doing frequent bites of that kerosene, I was getting frequent durotomies, but I haven't had anybody really that I had to bring back to a repair because these incisions just heal so well. Mm-hmm. I don't use the glues. I typically just roll up a tiny gel foam and just plug it like a tire. And I just kind of leave it at that. Yeah. I still discharge them the same day.
Yeah. No, I agree. I think the one thing, there are some people that put in a second port, because if you put in a second port, you could sew it. So that would be something to think about. Let's say if it's a humongous tear and it's just spaghetti, that's a different story. Thankfully, I haven't had that happen yet. And the reason why, if you're thoughtful and you're careful, because the visualization is perfect. Like a lot of times you're like, oh, I didn't see that bite. But in endoscopy, you don't have that excuse. You're supposed to see every bite. If you don't see every bite, then you shouldn't take that bite. So that's why I think that's the reason why. But I think if it's like spaghetti, you could put a second port to close it off, or open. Okay. And that's kind of, in my mind, I haven't gotten to that point, those last two things, but those are on my mind always.
Great, thank you.
Great,
Thank you.
Thanks, Osama. So, we're transitioning to the endoscopic cervical frame anatomy with